Sleep apnea, sleep disordered breathing, respiratory depression, and combined with obesity and combined with surgery. Bad combination, dangerous combination. Okay? Going to sleep and waking up with surgery by itself has some risk. It's pretty low, but going to sleep, waking up, placing the breathing tube, being under anesthesia has some risk. There are some dangers to it. It's increased the heavier you are. It's increased the sicker you are. It's increased the more underlying lung disease that you come with, whether it's from the brain with decreased drive to breathe, or from the chest and the lung itself. We are very, very attentive to that, and so the anesthetic technique that we use, the drugs and the way we treat our patients, is widely different than most anesthesia because of that concern. Okay? So we use a highly specialized, very unique, not widely used yet type of anesthesia called opioid-sparing analgesia and anesthesia. Opioid-sparing analgesia and anesthesia. The idea is that when you go to sleep, two classes of drugs are routinely used in the United States and around the world. They're cheap and effective and very good drugs. One are gas anesthetics. And if you're way old like I am, the original gas anesthetic was ether. Okay? Now it's a long time since ether was used. We now have the desflurane and other newer volatile gases to breathe in for anesthesia, but these gases still have two big issues. One that's annoying and one that's deadly. The gas anesthetics, up to 1/3 of patients will sustain nausea and vomiting after they wake up because of the gas. And that's no fun. The other, more concerning, is that after you wake up from the gas anesthetic, a certain number will sustain a decreased breathing, or respiratory depression. Respiratory depression, decreased breathing after the surgery. The gas anesthetic, which is fat soluble, will come back into the system from the fat unexpectedly in the early postoperative period and decrease breathing. And if you also have surgery on the belly and extra weight and sleep apnea, that combination can drop your oxygen, cause an irregular heartbeat, arrest, and potentially death. Gas anesthetics routinely used, very good drugs, nausea and vomiting in 1/3, respiratory depression is a danger. The other common drug that's used to treat patients during and after surgery is narcotics. And narcotics are wonderful because of their power to relieve the feelings of pain. And we give thanks for those every day. They're wonderful. But again, the narcotics, like the gas anesthetics, two complications. One, nausea and vomiting. Ever taken codeine and gotten sick on your stomach? Narcotics can make you sick on your stomach with nausea and vomiting. But the more dangerous one, again, is respiratory depression. How do people who die from an overdose of narcotics die? They stop breathing because the narcotics depress their respirations. So when we have our patient wake up after having surgery, they have pain, and we say, oh, we'd better give some pain medicine. We give narcotics. They have some gas anesthesia. Maybe they get respiratory depression. All of a sudden, tragedy. Those are standard techniques. You be careful and you can use them, but there's a new way to treat patients that we use. We got rid of the gas anesthetics. We use something called propofol, which is an intravenous anesthetic. Okay? It's an excellent anesthetic as long as you use it in the hospital. Goofy doctor who was taking care of Michael Jackson was using it at home. This is a bad idea. So doing general anesthesia at home with propofol, deadly. We use that drug though, and the reason that that doctor had selected it because of its safety, but he was not doing it in an operating room. But we get rid of the gas anesthetics because you get rid of the, hi guys.
Hey.
We get rid of the respiratory depression, and nausea from using gas. The other thing we do is we want to use pain medicine that gives you less pain and uses less narcotics. Now, narcotics work because they go into the brain and lock into an area in the brain that's called a receptor on cells, and so pain goes away. And opioid-sparing research is saying maybe there are other places in the brain we can find other kinds of drugs where we could get pain relief and not have to use so much narcotics. We can use opioid-sparing. And we use 2 primary drugs plus some other common medicines you're familiar with. The 2 big drugs are, one, an old-timey drug called ketamine. Ketamine's been around for a long time. It's not used for general anesthesia by itself because it causes you to have hallucinations. But instead of depressing respirations, it stimulates respiration, so you breathe more. That's good. And it takes away pain, and it's an antidepressant. So you feel happier for a week or so. So ketamine is opioid sparing, and the other drug we use you probably have not heard of is called dexmedetomidine, or Presidex, and it works on the alpha-2 receptor. Ketamine works on the N-methyl-D-aspartate receptor, and that combination decreases pain and stimulates respirations, and we use less narcotics, so there's less respiratory depression. And that combination of total intravenous anesthesia, called TIVA, and opioid sparing is the type of anesthesia that we use for your surgery tomorrow, and it's tremendously improved respirations in the recovery room and decreases the depression that we get from the gas and the higher doses of narcotics.